you for joining us this evening for the next of our consultant forum meetings. There is a wide invite to lots of our campus partners as well as our ICS partners. So welcome to those of you who don't normally work at CUH. It's a great pleasure this evening to introduce two people to you. Sue Broster, who's my Deputy Medical Director colleague and our Interim Executive Director of Improvement and Transformation, who's actually going to chair this evening with our speaker, Professor Don Berwick, who is Emeritus Professor and Senior Fellow at the IHI, amongst many other achievements. And we're really looking forward to hearing from Don this evening around quality improvement. So without further ado, what I'm going to do is hand over to Sue. We look forward to hearing from Don, and then please do use the chat facility and ask questions later so that we can maximize our time with Don. So Sue, without further ado, over to you.
Thanks very much. Thanks, Justin, for that. So welcome, everybody. It's particularly exciting to introduce Professor Don Berwick tonight, particularly as we've just launched our work with the IHI last week with the coach and team programs, which some of you may well be on. So, and Don's a leading authority on healthcare quality and improvement. So I think is hopefully will give us a bit of inspiration and help us as we start our journey working with IHI over the next few years. So really it's an inspiration for those of you on the call like me, as a paediatrician by background, so somebody that I've long looked up to around the quality improvement with a strong paediatric background, and as a clinical professor of paediatrics and healthcare policy at Harvard, and a member of staff at Boston Children's, Massachusetts General, and the Women's Hospital for some time. He's also worked with two US presidents. President Obama in 2010 appointed Don Berwick to the position of Administrator of the Centers for Medicare and Medicaid Services, and previously had worked for President Clinton's Advisory Commission on Consumer Protection and Quality in the Healthcare Industry, which has won numerous awards, including the 2007 William B. Graham Prize for Health Services Research and the 2006 John Eisenberg Patient Safety and Quality Award. More recently, in 2005, he was appointed Honorary Knight Commander of the British Empire by Her Majesty Queen Elizabeth, one of the highest honours in the UK for non-UK citizens, and regularly publishes on scientific articles and books all around, mainly around quality improvement. So a really sort of inspirational speaker for tonight, and I hope will really set the scene for many of us as we look to the next few years in the Trust, really taking how we work through improvement at CUH, being inspired by what we hear tonight. Don, over to you. Thank you.
Thank you, Sue and Justin. Let me just make sure my audio is working properly. Can you hear me okay?
Yes, we can.
Great. Well, it's an honor to get to be with you, and my only disappointment, it's not in person. I've spent many wonderful days and weeks and months in the UK, and I can't wait to get back there and hopefully pay you a visit in person. My main affiliation is still with the Institute for Healthcare Improvement as President Emeritus and Senior Fellow, and I will hope that my IHI colleagues call on me to be directly involved in the work that will be ongoing between COH and IHI. What I want to do in the short time we have together today is sort of go to basics. My career and the work at IHI has been centered around modern concepts of improvement. I'll say that what you do at CUH is very important. You're an iconic institution, and I think it's not trivial that you do what you're undertaking now, which is to master systemic improvement as science and to apply it to everything you do. And I'd love to be able to help you. But to that, I'm going to go back to some basics with you, and then leave time for questions and answers. The healthcare times are difficult. This is a list of the many challenges that we're facing in countries all over the world. COVID-19, the constant increase in chronic illness burden with our aging populations, stresses in primary care, this major dislocation of moving into virtual care, new ways to give care, widespread consciousness in all our countries about ongoing and embarrassing problems of equity and failure to invest in improving social determinants of health, all of this affecting physicians and relationships with physicians and nurses and other professionals. And then all of this always under financial pressures. Recently in the UK, especially the austerity budgets of the past decade, which were tremendous stresses, I know. And all of this is done under heavy surveillance, both by the public and by official agencies. This is the world we're living in. I regard being a physician to be an honor. It's a noble profession and should be joyous to work in. But sometimes joy is hard to find because of the constantly changing pressures we're all under. I'm going to give you a little bit of a sociologic interpretation of this. This is a bust supposedly of Hippocrates, who represents to me what I would call era one in medicine, still with us. I got this idea originally from an American social psychologist, Elliot Friedson, who was a sociologist of healthcare, but he wrote a wonderful book called Professions. He was trying to understand what it is that defines professions, and he took healthcare as his example. And he basically said this. He said, healthcare, a profession, is a work group that reserves to itself the right to judge the quality of its own work. It's a work group that reserves to itself the right to judge its own quality. And he noted in his book, Profession of Medicine, that this is rather unusual. Most work groups can't judge their own quality. If I go to a hotel, I'll judge the hotel. Thank you very much. They don't judge their quality. I do. I'm the user. If I go to a restaurant, I'll judge the quality. I'll tell you how good the meal is. The producer doesn't get to tell you how good the production is. But Friedson says, no, professions are different. Society says the profession, you can judge your own quality. And this goes back for millennia. And he asked the question, why would that be? And this is his answer. He says there's sort of a contract, a social contract, in which the profession, and this is the definition of profession, is presumed by the public to be noble, to put its own interests behind the interests of the people it's serving, to have specialized knowledge that others can't have access to, and that the profession will clean its own house. When things go wrong, it'll self-regulate. And Friedson laid out these as the conditions of the social contract that allows the profession of medicine to judge itself. I call that era one. And it's full of an ethos, of kind of cultural assumptions. The profession will be trusted. It'll have certain prerogatives. You know, there'll be the doctor's dining room, so to speak. And my father was a doctor in a small town. I remember one night him taking a phone call, and then he just yelled into the phone. He said, "I'm the doctor. You'll get penicillin when I say you get penicillin." This was the right of the profession, and it'll be scholarly and take care of its own and expand knowledge. That's the era one ethos. This ran into trouble 20, 30 years ago. Health services researchers in both of our countries began looking at the performance of healthcare. And what they found was quite disturbing. These two reports came from our National Academy of Medicine in 1999 and 2001. The first report was on errors in care, mistakes and their consequences. And it famously in my country reported that 44 to 98,000 people a year were dying from mistakes in healthcare, from errors in care. That report was called To Err Is Human. You had a similar report overseen by Sir Liam Donaldson within a couple of years of that, called An Organization with a Memory, which made the same point about errors in care in the National Health Service. 2 years later, in 2001, already 20 years ago, the National Academy published this report, Crossing the Quality Chasm, which laid out a series of statements about evidence-based performance of healthcare, what was going on, and set out aims for improvement, 6 of them. I originally wrote this list. I was on that committee, and the aims were healthcare had safety issues, back to Err Is Human, problems of effectiveness, variation in care, what you would call a postal code lottery, in which variation, what happened to the patient depended on where they went, not about the science so much, and there was tremendous variability. Patient-centeredness had to do with people's feeling disempowered and not heard in healthcare. timeliness were delays. And in the time I first became involved with the NHS, it was all about timeliness. That was in the era of Tony Blair when he first came in which the public was quite outraged about delays. Efficiencies, reduction of waste, and equity, closing racial and socioeconomic gaps. And these aims for improvement, safe, effective, patient-centered, timely, efficient, equitable care, were all underpinned by evidence that this wasn't what was happening, not with high reliability. The statement about what needs to be made better in healthcare got kind of more expanded. It got expanded by colleagues of mine named John Whittington and Tom Nolan, very important faculty members at IHI, in about 2004, 2005, who said that the Institute of Medicine aims for improvement were about what should happen when you're in the care system. It should be safe, effective, patient-centered, timely, efficient, equitable for people, individuals in care. But they pointed out that the causes of illness were not in healthcare. Healthcare is a repair shop, as Lord Nigel Crisp has written about in his recent book, and that the causes of illness actually lie in the conditions of society, social determinants of health, so eloquently worked out by Sir Michael Marmot in your country in his book, The Health Gap. And that all of the, if we really wanted to work on health, that the Institute of Medicine aims, the 6 aims for improvement, were not enough. We had to work on health of populations, not just experience of individuals. And all of this should be done without waste, that we should reduce the constant drain on the treasuries, public and private treasuries, by healthcare by removing waste. And so this became the triple aim: better care for individuals, better health for populations, lower per capita cost. This is a kind of a crisis, because if the assumptions of era 1 were all about trust, they get violated in the scrutiny of the Crossing the Quality Chasm report to Err is Human. The public begins to say, what's going on here? You said you'd be beneficent, but you're killing 44,000 people a year and you didn't tell us. You'd say be self-regulating. What's going on here? You say you'd be scientific, but we're hearing that there's variation in care, which is phenomenally large. 3-fold, 4-fold, 5-fold differences in surgical rates or testing rates, depending just on where you live. You say you would put others' interests before your own, and yet you seem to be taking more and more money without the results being in hand. There actually was a turning point in the 1990s, 2000s around public trust. And the understandings that underpinned the social contract that Elliot Friedson wrote about, the era 1 contract, got violated, or became known to be violated. And so there was a reaction from government, the public, from payers saying, hold on a minute, deal is off. You thought you could judge the quality of the work you do? No, you've not held up your end of the contract. And meanwhile, of course, era 1 is fully at work as proud physicians, responsible people trying hard every day to relieve pain and cure illness, are working away under the era 1 ethos of I'm a professional, I want to do well, and suddenly find themselves in a kind of combat with era 2 scrutiny and suspicion. And it's not good. It's a source of problems. There's a metaphor for the problem that I found a few years ago, which I'll just show you just for the fun of it. This is a bridge in Honduras, the Choluteca River Bridge. It was built to cross the Choluteca River in 1938. Very, very strong bridge, very important in Honduras, which has very bad weather, very, very, especially hurricanes during hurricane season that are quite violent. And the bridge was built to withstand hurricanes. And indeed, it got stressed. In 1998, Hurricane Mitch, a terrible hurricane, hit Honduras. It devastated towns and cities in Honduras. It took down many, many bridges, killed many people. But the Choluteca River Bridge, which was built so strong, didn't fall. It survived. The problem was the river moved. And so now there's a strong and wonderful bridge in the wrong place. You can kind of think of this as a metaphor for some of what we're dealing with in the healthcare world. It's our systems really weren't built for a lot of the stresses that they're now being subjected to. We weren't built to deal with chronic illness. We were built to deal with acute illness, with technocracy. We weren't built for behavioral health care as a mainstay issue. We weren't built for a lot of the problems that that now are part of the modern era. You saw how troubled we were dealing with pandemics. This is a misleading metaphor because, of course, there is a river under the bridge still, which is the technocracy river. When I was a trainee in pediatrics, every kid I saw with leukemia died, but within a decade, they all lived. And it's because we built that strong technocratic bridge does work when it's needed, but the big social need for health and well-being, the triple aim, meeting the needs of the National Academy of Medicine's 6 aims, no, kind of we need another bridge. And the problem is that in the combat of the conflict between era one, I'm the professional, I'm noble, I'll do my job, I'll be a scholar, I'll take care of my own, I'll clean my own house, and the scrutiny of era two, which is, wait a minute, the data don't suggest that we're being so successful, you end up in a combat that cannot build a bridge. There's no way for healthcare to design and redesign itself under these conditions of tension, which have emerged in my professional lifetime. So what do you do when there are problems? Part of the issue is that the usual approach to dealing with, call them quality issues, problems of safety and effectiveness and patient-centeredness and timeliness, efficiency, equity, problems of a mismatch between need and work, elicits a kind of reaction that is highly dysfunctional. You have lived with in the UK in the entire time of my association there. The name of this is well known in many areas, many industries, and one way it's often referred to is reliance on inspection to improve. And here's what it means. So now we have a problem, safety issues, patient satisfaction problems, waiting times. So we'll get this under control. Whoever is responsible, we're going to measure it. We're going to define this problem, measure waiting times, measure whether we're hitting targets, measure survival rates, and we're going to study everybody, study all the hospitals, all the surgeons, all the doctors, all the population, and then of course we're going to get a curve of distribution. So these are all the hospitals, let's say in England, and their surgical survival rates, or their patient satisfaction levels, or maybe this is their meeting of targets, and we'll then find the ones that are deficient. And we'll do something about them. We'll fire them, we'll close them, we'll shoot them, we'll re-educate them, we'll put them in special measures. We'll find the problem and fix the problem. And that the name of this approach is reliance on inspection to improve. Do the work, inspect it, decide what's acceptable, and it's unacceptable, do something about it. It's very attractive. It's hegemonic. It's everywhere in our Western societies anyway, but it doesn't work. It just doesn't work. It works a little bit. I mean, if there are some real egregious problem areas, yeah, maybe something will happen. But for most of us, we're not the problem. Most of us, most of the time, are just trying to get our work done. It's a very, very weak way to build a new bridge. In the work of the IHI and the work you'll be studying in our efforts together over the next few years, this is the underlying scientific principle that will have absolute power. It is that every system is perfectly designed to achieve exactly the results it gets. This came to me first from my colleague, Paul Batalden, who's co-founder of IHI. Paul said, every system is perfectly designed to achieve exactly the results it gets. You know intuitively what this Zen sentence means. If you own a car and it's 12 years old, and it has a top speed, let's say. If you take it out on the straight road somewhere and floor the accelerator, it'll reach a top speed. That is the characteristic of the car. You may like it, you may not like it. You may say it's too slow or not too slow. But whatever the top speed of the car is a property of the car. If you don't like the top speed, you'll need to change something. You'll need to change the fuel injection system. You need to change the weight of the car. You need to get a new car. You can't yell at your car or give it incentives or put it in special measures to change its top speed. It can't change. It's a property of the car. But every system we work in, including Cambridge University hospitals, including healthcare, has its top speeds. It has its mortality rate and its satisfaction level and its cost and its safety level and its waiting times. And all of those are, they're as characteristic of that system as the top speed of a car is of a car. If you want a new performance, you need a new system. All improvement is change. Not all change is improvement, but all improvement is change. And this is the fundamental scientific foundation of modern improvement, everything you'll be learning with IHI. The help in understanding what an improvement system looks like comes from many people, but including Dr. Joseph Juran. Hopefully, Dr. Juran's work of the past century. He was a brilliant man, a chess grandmaster. He died at 103 and wrote many books about improvement that we use all the time. Juran tried to describe what a true system of improvement looks like, not the reliance on inspection, but a scientifically grounded improvement system that takes full cognizance of the first law that every system is perfectly designed to achieve the results it gets. And what Juran said was, if you want, Cambridge University Hospital, if you want to be ever better all the time, you'll have to have 3 processes in place. He called them quality control, quality improvement, and he called it quality planning. I call it invention here. It makes it a little clearer. Quality control. Quality control is fixing a problem that's not characteristic of the system to get it back into the system. A typical example for me is a flat tire in a car. If I'm driving my automobile and the tire goes flat, I better stop the car and I better change the tire. A flat tire is not a normal property of a car. It's an exceptional event, an outlier that needs to be fixed. And all of healthcare has that all the time. That could be an outbreak of a disease. It could be an alcoholic surgeon. It could be there are all sorts of things that can go wrong. And you need to know when that happens and you need to get it back in order. That's quality control. Quality improvement is quite different. Quality improvement is just another word for learning, continuous learning. My wife and I have been working the past few months on pea soup. We really like pea soup, but we think it could be better. And so every time we make pea soup, we change something. We add a little. Last time I think we added a little more curry. We put curry in pea soup. It turned out it makes it better, but we put too much curry in the last time. We tasted it and found out. So actually, we're having pea soup tonight, but it's going to it'll be a little bit closer to the best curry we could put in it, best amount. It's the continuous learning process. I know a continuous learner. He's my grandson, Nathaniel. Nathaniel is an avid baseball player. He loves baseball. And he takes every opportunity he can to get out in the yard with his baseball bat and hit the ball and see if he can hit it farther. Or he'll ask to play catch with me or his dad and see if he can catch the ball better. Or he's a learner. He's constantly saying, "Papa, am I standing right? Am I holding the bat right? Why did that ball go in the wrong place?" He's constantly trying new pea soup around baseball. That is the journey of improvement that Juran is talking about. The third area is complete and reinvention, doing something completely new. The telemedicine is a good example. That's not actually an improvement. It's not a marginal change in a consistent system. It's layering in a new system. It has to have new properties. Juran says if you, Cambridge University Hospital, you want to be the greatest medical institution in the world, you need to do all 3 in approximately these proportions. When the tire goes flat, fix it. Make sure you've got energy to find the entirely new way to deliver care, just as you do in biomedicine, as we cure cancer or figure out how to do organ transplants, inventing new stuff in approximately this proportion. But most of the time, everywhere, involving everyone, be Nathaniel, learn, constantly have a mechanism for trying to change what you do over time, because every system is perfectly designed to achieve the results it gets. If you want a new result, you're going to have to try some changes. Unfortunately, because reliance on inspection is hegemonic, in most systems, including yours, this is how it feels. The workforce doesn't feel that there's a constant process of changing one's work all the time, learning how to do it better, like Nathaniel playing baseball. Most of our time is spent in control space. Here comes the inspector. Here comes the contingency. We will be watched. We will be studied. We will be judged. So just getting through the process is the process of managing control, not improvement. And that's sad. That fails to make us the learners we could be. When you're in the learning mode, that is Nathaniel's mode, you have a method, and this is what the method looks like: pea soup or baseball. You have to answer 3 questions. What are you trying to accomplish? Better pea soup, hit the ball farther, end pressure ulcers at Cambridge University Hospital. How will we know if a change is an improvement? Well, we're going to need a measure. So Nathaniel has to know where the ball went. My wife and I have to taste the pea soup. And you better know how many pressure ulcers you have. Otherwise, when you make the changes, you won't know if things are getting better or not. And then find a change that might result in improvement. It was my daughter, Jessica, who suggested curry and pea soup. Nathaniel learns better baseball by watching baseball games or reading books about baseball or asking his coach or asking his friend who is a better baseball player than him. Find something to try out. That's the basics. We call it the model for improvement from our friends Tom Nolan and John Lloyd Provost and Kevin Nolan and others, associates in process improvement. But that isn't enough to make better pea soup or ride a bicycle better. You better get on the bike. Nathaniel can't learn to ride a bicycle better or play baseball better if he doesn't get on the bicycle or get on the baseball field. And this is the plan, do, study, act process. It's the democratization of science. It's the local constant effort to learn by doing. Add a little more curry, taste the soup. Do you like it? Keep the curry. If you don't like it, change the curry. Change my position of hands on the bat. Did the ball go farther? If it did, keep it. If it didn't, try a different position. Pressure ulcers. Who's got the lowest pressure ulcer rate in the entire National Health Service? Let's send a team to visit them and find out what they do different about skin care from what we do. And then let's see if we can bring that home locally. That's totally different from reliance on inspection. It's reliance on learning, and it works. It works in England. This is Sir John Oldham. John, I hope you know him. You should bring him to Cambridge and have him do grand rounds. John was a physician, a general practitioner in Glossop in Derbyshire, at the time when Tony Blair became particularly concerned about primary care waiting times, general practice waiting times, which were a major political issue back in the late 1990s, early 2000s. For various reasons I won't go into, John Oldham was named to become the head of the National Primary Care Development Team, PCDT, which existed for about 5 years under the aegis of the Modernization Agency in the National Health Service in the early part of the 2000s. John used modern improvement techniques. He used queuing theory and modern approaches with an organized set of networks around the entire all of England. By the time John was done, he was covering all of the English National Health Service with 11 local organizations, helping GP practices all over the country learn and study queuing theory approaches using the PDSA cycles and the model for improvement I just showed you. And over a period of time that's remarkably short, about 18 months, John began to get in the GP practices all over England massive reductions in waiting times for GP access. It was done in 3 waves. Notice wave 1, which involved about a third of the practices, took about 14 months to get profound changes in access. Wave 2 took less time. Wave 3 took less time. Why? Because they were learning. They were doing, as a nation, you were learning how to reduce GP waits with, by the way, very little, if any, additional resources. It was all done by changing the processes of scheduling and for patients. Scotland's been ahead of England. The Scottish National Health Service has done more than almost any other country I know on clinical process improvements, especially beginning in surgery back a few years ago under the leadership at that time of Derek Feely and Jason Leach. In a 6-year period, 2009 to 2015, Scotland achieved a 23% reduction in surgical mortality, and they did it with a systematic set of efforts around PDSA cycles and improvements for 5 or 6 critical processes in surgical theaters in Scotland. More recently, IHI has been working with an amazing collaborative process in Brazil This is a project, the one I'm showing you is called ProAudio, although there's another one started more recently. This worked on hospital-acquired infections. The ProAudio goals were throughout Brazil to reduce catheter-acquired urinary tract infections, clinical bacteremia, central line bacteremias, and ventilator pneumonias. This project was very big. It involved 116 public hospital intensive care units all over Brazil, although largely in Sao Paulo state. 5 big hospitals were chosen as hubs, with 24 hospitals connected to each hub. And in this network process, connecting networks, much as John Oldham had done with waiting times back in this early part of the century with GP practices, they set out quite ambitiously to reduce central line bloodstream infections, catheter-associated urinary tract infections, ventilator pneumonias by 50% in 36 months. They beat their goal. This shows the actual metrics of central line bloodstream infections per 1,000 central line days. Overall, 116 intensive care units participated. This is the results for catheter-associated urinary tract infections. These are the results for ventilator pneumonias. This did not happen through exhortation. It did not happen through control and inspection. It happened through learning. At the system level, we are learning more and more about what the new system that could be birthed would look like. I have the pleasure of being one of the key guides to the Institute for Healthcare Improvement Leadership Alliance, the American collection now of 55 American organizations working on comprehensive redesign. There is one in the UK and in Europe. It's called Health Improvement Alliance Europe, also started by IHI. I should know, but I don't know if Cambridge is part of it. But it's about also about 40 organizations that are working on the triple aim: care that better than we've ever seen, health better than we've ever known, costs we can all afford for everyone. They're working now with 10 design principles, each one using the same kind of model for improvement approach I just showed you, changing the balance of power, putting much more control in the hands of patients and families and communities. Turns out to be a major set of changes for getting better results. Standardization of what makes sense. Variation, when it doesn't make sense, is an enemy of quality. It's an enemy of outcomes. It raises costs. And so agreeing to standardize makes a lot of sense. And customizing to individual. This is what matters to you, medicine, as my colleague Maureen Bisignano has led really worldwide. Instead of saying what's the matter with you, individual care is organized around what matters to you. The fourth change is to work upstream on social determinants, promoting well-being. The fifth is working on joy and work for the workforce, building all sorts of processes, evidence-based processes for supporting the pride and the joy of the workforce. The sixth principle is making it easy. This is reduction of non-value added activities. For example, 24 organizations in the Leadership Alliance asked their patients, staff, and families what were stupid rules in the system that stood in the way of taking good care of patients. They nominated 360 stupid rules in the first week of that work, and they began removing those rules. This has to do with moving knowledge, not people. That's moving care to virtual space, which I know you're more experienced with now. High levels of collaboration and cooperation. Using the abundance that we have instead of constantly looking outside for more. Tremendous amount of resource inside organizations that's not tapped. And this is reducing prices, which is an important American goal. Major changes can happen in redesign. I love this picture that I got off the web. This is St. Peter's Square in 2005 at the election of Pope Benedict. This is St. Peter's Square in 2013 at the election of Pope Francis. Complete tectonic change in technology in an 8-year period. We can do massive things with redesign. You've tried that in England. The English NHS has undertaken, under the leadership of Sir Simon Stevens, big plans for redesign, some of which have gone rather well. The 5-year forward view, followed more recently last year by the NHS long-term plan, is a very capacious set of ideas for redesign. never, ever, ever could be accomplished by reliance on inspection. Only by learning, only by improvement, only by continuous work on the changes and the thematic improvements that you're after. The long-term plan is well worth study, but it can only be implemented as a learning system. You've had enough experience in the NHS now in 20 years of work on improvement to know what the rules are. You cannot cut your way to efficiency. You have to find waste and root it out. You cannot blame your way to safety. Naming and shaming is bankrupt. You have to learn and embrace and practice safety science. You can't exhort your way to excellence. The best speeches don't work. You have to embrace the design and redesign and continue learning that the Parati project used and that John Oldham has shown can work in the UK. And you can't require this. There's no set of rules is going to make CUH change and into the new place it can become. It has to be done by invitation, by teamwork, and by joy. And it's going to have to be done in the community. Hospitals are not the future of healthcare. If we're really interested in well-being, is going to lie in social determinants, compassionate social policy, justice, and equality. And you in Cambridge, you can fight for that too. You have a platform now. I firmly believe that the ICSs, the integrated care systems that are now emerging as the architecture of design for the English National Health Service as of April 1, is a tremendous opportunity. The concept of place-based redesign, in which localized systems like yours can begin to have the budgets and the responsibility to actually reshape care toward what it needs to be. I think that is brilliant. And I think if you can run with it at CUH, you can change everything. I've gone a little over time. I'm sorry about that, Sue, but let me stop there, and I'd welcome as much time for dialogue as we have now.
That was absolutely fantastic. Thank you very much, and a great introduction and really inspiring for us who are about to start on that programme with IHI. Now there's quite a lot of screens, just so that for those of you who want to put up your hands, if you could type something in the chat box, that would be helpful. Otherwise, you're going to have to wave at me really vigorously, because otherwise, scrolling across 4 screens, I run the risk of missing you. So I don't know whether anybody's got any question immediately they want to ask. Otherwise, I can think of a couple while other people type. Okay, I'm going to assume that you're all typing vigorously at the moment. Well, so Don, a couple of things that just came to mind for me whilst other people type. One is sometimes people are scared of failing, and that maybe holds us back from really driving forward with improvement. What's your thoughts and reflections on that?
What would I tell my grandson Nathaniel when he was learning to ride a bicycle if he said, "I don't want to fall"? I'd have to say, "You will fall. Of course you'll fall." You know, the process of learning is exactly the process of exploration, in which the failure can be the most instructive of anything we do. In the economy of the psychological economy of inspection, failure is a danger. The last thing you want to do is fall, because the CHCQC is going to show up, or the Guardian's going to write a story, or what you got to get. The psychology's got to change, which is the whole idea is to try things and learn from what you're trying. Now, in medicine, we don't want to take risks with our patients. And so if you're going to do something that's changing patient care, put a safety net under it. You're smart enough to protect the patient as we learn. But I would say, Cambridge, welcome failures. It's the part of the joy of learning. It's the way to find the future. And you need a leadership system that knows that and values it, and that protects you against the consequences of reliance on inspection scrutiny. But I think that the fun of this is in learning. It's really joyous. You should watch the Parati project, which could bring you to Brazil. Those literally thousands of people working on infections, and they're having a lot of fun.
Thank you. So there's a question from John Boyle, who asked, is there still a role for publication of surgeon level outcomes in an era of MDT working and team-based care?
It's, you know, that I wouldn't be arrogant, John, enough to say that I know for sure, because it's contextual. It depends on the cultures around you and stuff like that. But I would say overall, yes, because here's the deal. In the long run, not the short run necessarily, but in the longer run, transparency is going to help. We just can learn so much more if the lights are on. And if I know how you're doing and you know how I'm doing, we can ask each other questions. Oh, gee, I didn't know you did it that way. Tell me more. it's very hard to be partially transparent or protectedly transparent. And so I think, call me naive, and you probably will, but I think the best place to go at Cambridge is to say, let's go for it. What we do can be known by others, so we can know it, and then we can learn. And by the way, if other prestigious hospitals like yours are willing to be totally transparent, sure, you can learn. If you're a surgeon, don't you want to know if there's somebody in the country with a great outcome that you don't have? Of course you want to know. And it's very hard for you to know if the public can't know. So I would leap over this one and try to embrace transparency. I know it's scary, but frankly, I have generally found when places leap over the fear, it turned out the fears were largely unwarranted and things are fine, except you can learn faster now.
Thank you. And a couple more questions have been typed. So one from Sue Robinson. How would you change the approach to regulation and inspection in the NHS so that it drives support and improvement?
Yeah, I mean, I wish I could. I wrote, as you know, I chaired a commission in the UK for David Cameron during his period, which published a report on Mid Staffordshire called A Promise to Learn. And in that report, I think my colleagues and I took the best shot possible in answer to Sue's question. I think it's you have to know if the tires are flat. So there has to be some system to find something really egregious. There was some real problems at Mid Staffs that were not known for or not acted on for years. So you have to have some inspection regime. That's part of the Duran trilogy, but fear is the enemy of improvement. It's incompatible with improvement. And so you have to find a way to have an inspection orientation which does the job, but really works hard to reduce fear and blame in the system. And that's what I wrote in that report, and that's what I still believe. Is it possible? Yeah, sure, it's possible. Any school teacher running a wonderful classroom does that. She knows if the kids are scared, they're not going to learn. And she knows sometimes there'll have to be some discipline, but I think we could get that balance right. So that's how we'd coach. It's very hard in politics because the press are always out there watching, looking for some story to tell. And I just think for leaders, it means you have to put up an umbrella and tell people to go ahead and try things.
Thank you. And then Ken Poole, the stupid rules survey idea is really powerful. Can you give some examples of what was dropped, and was anything that was dropped similar to what was dropped during COVID-19?
I don't know the answer to the last thing. I almost certainly the Stupid Rules project in the US surfaced 360 rules in 24 organizations in 1 week. It was repeated by HIAE, the European Alliance, that I hope maybe Cambridge would join. And that alliance did the project and had more nominees and more success. And I think Corinna may be able to get the exact list. They were rules like in the US, there were payment rules that didn't make any sense. For example, a rule that we're still working to drop, but it says that you can't send a person from a hospital to a long-term care, to a nursing home, until they've been in the hospital 3 days. Even if you know it one day they're going to need long-term, that would be a regulatory rule. But most of the 85% of the rules that were surfaced were actually administrative rules, that is under the prerogative of the executive of the organization, not a legal requirement, or not rules at all, just habits or myths. For example, the rule that visiting hour rules, those were very common. The patients and the families hated them. The idea that an institution can tell a wife she can't be with her husband. People say, why would we ever do that? And a lot of the changes had to do with opening doors and letting people be in more. Now, COVID actually made that more difficult temporarily, but that will go away. There were rules about things like hassles for the staff. Like you can't have a glass of water on your desk was one rule. And there were dozens and dozens of these small rules. I perhaps if Corinna can work with HIE and get you the rules list, you'll enjoy it. I would recommend, you could do it right now. You could do it in the next month at Cambridge. Survey all of your staff, all of your patients and the carers, and ask them that question. What are rules that appear to you stupid, if that's not too insulting, that stand in the way of great patient care? and then collect them and take a look at them, and you'll find plenty you can change.
So I think that sounds something that we should definitely be taking the opportunity to do. So something for us to talk to Corinna about after this session. A question from Caroline Liebus was, it can be harder to standardize care in general medicine. And how do you think we can get the correct balance between standardization of care versus leaving enough room for clinical acumen and finesse?
It's a great question, Caroline. The answer is common sense. Basically understand that when there's variation that doesn't help anybody, it adds waste. And so here's an example. This is a little edgy, but I know I'm talking to consultants, so perhaps you've done this already at Cambridge, but at Intermountain Healthcare, they did a project, I believe it was there, on orthopedic surgery on the trays. You know that I don't know what you would call it in the UK, but when the surgeon comes in the room, there's an instrument tray ready for that procedure. So for hip replacements, typically in an American organization, you'd have 8 orthopedic surgeons, let's say, and each one has their own tray. There's Dr. Smith's tray, Dr. Jones' tray, Dr. Berwick's tray, and the sterile supply department knows it has to set up each tray for each doctor, and that's because Dr. Smith was trained at Hopkins and Dr. Jones was trained at San Francisco, and they all want their tray. Well, that adds tremendous complexity to the central supply rooms, complexity of procurement. There are of course more mistakes because it's a more complex system. When everyone agreed, that surgeons got together and said, let's have one tray, everything got better. The error rate went down. You didn't have to cross-train staff. The complexity in the surgical supply room went down. Supply costs went down because bulk purchasing could be done. Everybody swallowed a little bit of pride and said, let's standardize, and they got better results and lower cost. That's one example. Standardizing to protocols. If there are 3 or 4 ways that you're using transfusions, can you please agree on one? Or if you think there are 2 possible ones, do both, but compare the results. Use common sense. The reason why it's so important is precisely because of Carolyn's other part of her question. If you standardize everything you could, then there's much more room for adaptation to the individual. Then you really can ask every patient what matters to you and do it their way, because the system is so smooth otherwise. And believe me, that's a better place to be as a clinician.
Caroline, I can see you've come up on screen now. Did that answer your question, or did you want to follow up? Yep, excellent. Thank you. So there was a question from Ewa Ricks. Lots of improvement comes together with a change of culture, and I think that is something that we come back to a lot in our discussions. Are there any mechanisms or methods to help implement the change of people's approach and understanding? So that real cultural piece. Oh,
many. You'll be studying these with IHI. I'm going to make a point and then ask you a question. So one point is it's leadership dependent, that culture is first evinced in the behavior of the leader, and if the leader will get no culture change that he or she is not also doing themselves. If they want humility in a system, they better be humble. If they want authentic inquiry, they better be curious. If they want transparency, they better be transparent. And so I think explicitness in leadership about how they behave and then getting feedback about whether they're actually walking that talk, I think is crucial. Let me ask you, I had an interesting cultural event, and I want to ask you this. It's rather personal, but someone in my family had a problem, a minor surgical problem. It was a condition of her hand. And she went in about 6 months ago to a prestigious Boston medical facility and saw a physician's assistant. I don't know, you have those in the UK? Okay. So you saw a physician's assistant and said, "What is this?" Physician's assistant said, "Oh, I see these all the time." And he took out a scalpel and he incised, basically cut off the troublesome lesion. So it's very simple. And she went home and got sicker. Terrible pain, infection, and went back in and had another person look at it and did something, and then it got worse. And 6 months later, finally, last week, she went in for a definitive procedure by a capable surgeon. Capable surgeon looked at the hand and said, "What happened here?" And she told the story, and he said, "Oh, that's complete mismanagement. What that physician's assistant did is absolutely the wrong thing to do for this condition." And the person said to the surgeon, "Oh, well, why don't you call him?" And he said, "Oh, no, that's not my job." Now, that's culture. What would happen at Cambridge if that same story were told? Who among you, what would be, what do you want it to be? What do you want the answer to be? And how will you manage that? That's culture at work. And we need to learn that and improving of that and PDSA cycles on that, just as we do for surgical tray setups. I think that the key characteristic of a learning culture is curiosity and kind of a willingness to ask, how did I just do? What's going on? I think that physician's assistant who said, "I see this many times," is going to continue to make that mistake for the rest of his life, because the culture doesn't support learning.
No, I think that's something that we probably could all reflect on, is how we would comfortably, compassionately, kindly reflect on that with our colleagues that we work with, and also receive that in exactly the same way that conversation that we might have with someone else, that we might also receive it from someone to us. And I think that's something for all of us perhaps to think about.
What you can do is you can make that an improvement project. You can say culture it's just behaviors. And if you take my story and say, we would like Cambridge to be a place where the next phone call that surgeon makes is to the physician's assistant in, as you said, a compassionate, supportive way, says that you made a mistake, let me explain what it is, and where the physician's assistant says, not who do you think you are, but thank you very much. And that becomes the way. What would you do? How would you make that be the way of Cambridge? That's amenable to action.
Yeah, I think I can see lots of nods around the room, including the medical director and others of the deputies. So I think that's something for us to take away and really think about. So unless Justin, Ashley, anything that you want to add to that just now? No?
No,
Ashley?
Nothing specific, but I think you got to the end of your question, Sue, but I think it's fabulous challenge back to us to see what would we do in that situation in each of our departments, clinical, non-clinical. I think is a great takeaway for the evening, and a fabulous lecture. Thank you.
Actually, if I can mention one, I can't resist mentioning the work going on at Birmingham Children's Hospital on the other end of the spectrum. I'm sadly blocking on the name of the young intensive care doctor there who's led it, but there's a process at Birmingham for feedback for excellence. When something goes really well, do you take the time to tell the person that did it that you're really grateful for that, and make it known to everyone that happened? This culture of learning applies at both ends. And if I might just say, over the years I've known the NHS, to my distress, people begin to learn that they can't take the ball and run with it, that they can't do this themselves. It's a kind of learned helplessness. You don't have to be that way. If you like the world of learning, you can do it. You can change. And part of what I love about the learning culture is you take control. You don't wait to see what the center says. You learn. You just go ahead and do it. And I think, boy, I'll tell you, I think Cambridge's got everything it takes to do that. And now you've been handed the ICS platform, which I understand all the controversies, I understand the skepticism, but I believe you've been handed a tremendous opportunity to do true systemic improvement.
Oh, thank you very much. So I'm just coming up to 7 o'clock, and I'm conscious that actually, I think many of us could talk to you for an awful lot longer this evening. It's been an absolutely both inspiring and thought-provoking evening, and I've certainly got two takeaways. One for me is that generated lots of positive chat around the stupid rules idea. So I can see that's definitely going to be something. I'm seeing lots of nodding around the screens that we should take away, but also the real challenge to us to think about what do we want to be like as an organisation? How do we want to have those conversations in a supportive way, both challenging but in a positive way, but also to be challenged, and also to really celebrate, what's going well in a way that is well demonstrated by other organisations. And we've started to do that, but I think we'd all say there's always more that we can and we should be doing.
So the positive project is called Learning from Excellence, LFE, Learning from Excellence at Birmingham Children's, and it's a great program and something else you could put in. It's on the happy end of the scale.
Yeah.
Thank you.
No, and it's good to have some real positives, as well as to be thinking about things we need to change that aren't quite working as we'd hope. So thank you very much. I really hope that perhaps maybe later this year, maybe into next year, we'll actually get the opportunity for you to come and visit. We would be absolutely delighted to host you here and have another opportunity to talk to you. So thank you very much.
I'd be thrilled to join you. Thank you for raising the possibility, and thank you for the chance to spend this time with you. And thank you to Corinna for making this all possible.
Thank you very much, and have a nice evening.